Goedemorgen allemaal. Goedemorgen, welkom op het allereerste symposium voor het project NEED. Bienvenue. Le premier symposium pour le projet NEED. Le symposium se déroulera en anglais. Il y a la traduction instantanée. Les casques sont à l'entrée de la salle si vous en avez besoin. Dus het symposium wordt in het Engels gehouden. Als u graag de simultaanvertaling gebruikt, kan u een hoofdtelefoon nemen. So it's my pleasure to welcome you to the first NEED Symposium. We have a very interesting program with lots of different speakers who will be presenting aspects of the NEED program throughout the day. We had invited the minister to open the symposium. As you all are well aware, he's now in Parliament defending the new budget. So he sent us a video, which I will hopefully be able to start.
Ladies and gentlemen, thank you very much for the invitation. I cannot be with you in person, but I hope that my message nevertheless helps in setting the stage for what surely will be a day of rich and thought-provoking discussion. The NEED initiative has made significant progress in recent years, and today is another valuable moment to reflect on where we are and where we are heading. With the recent publications and the many ongoing activities, this is indeed the ideal moment to continue building together on the development of NEED. Your presence, your continued engagement demonstrate how relevant and timely the topic remains. I don't have to recount the entire history of the NEED initiative. As you know, Belgium placed a strong emphasis on a more needs-driven health policy during our presidency of the Council of the European Union. NEED was launched in that context already at the end of 2022. It was not a merely technical exercise. It was a deliberate choice to focus on what patients, healthcare professionals and society truly require. Together with KCE, Scienzano and other federal institutions, Belgium has assumed a leading role in Europe, responding to the need, the necessity for an objective and transparent approach to identify unmet health needs. Although attention for needs evidently diminished somewhat after our presidency, the initiative remains very much present. We continue to receive questions about need from patients, associations and parliamentarians, and that shows that the method is alive and that the expectations remain high. It also confirms the necessity of a framework that is scientifically robust and reproducible to objectify health needs, and that is especially the case in the context of increasing pressure on our healthcare system given limited financial resources and people. It's unsurprising because NEED is founded on a principle that is too often implicit, placing the patient at the center. Not as a slogan, but as a true starting point. A healthcare system aligned with societal value must begin with the needs of patients. We therefore look forward to the reports that will soon be published, including case studies on psychotic disorders, sickle cell disease and chronic fatigue. Important milestones have again been achieved in recent months. The first milestone concerns the publication of the NEED Toolbox and the NEED Protocol. These documents provide a comprehensive set of validated methods, including a standardized research strategy, a generic expert questionnaire, and clear guidance for patient interviews. All these tools are freely accessible to research teams in Belgium and abroad. And I think a uniform and transparent methodology significantly strengthens the quality and comparability of NEED studies. A second important step is the steady expansion of the NEED database. It now contains data on Crohn's disease, melanoma, long COVID, and more than 80 conditions included in the Belgian burden of disease study. And I like to underline this specifically. The Belgian burden of disease study is internationally regarded as a reference for this type of research. And the fact that these data are now partially integrated into the NEED database is something we can rightly be proud of. Taken together, these developments show that we now have a very robust scientific foundation. In addition to what has already been achieved, substantial work is underway that will bear fruit in the coming years. Research is ongoing into how artificial intelligence can be used to identify relevant data from grey literature more rapidly. New case studies are being prepared, including those on psychotic disorders, chronic fatigue, sickle cell disease, and oncology. And an ethical analysis of the NEED initiative is also in development. Furthermore, the integration of data from the Belgian Health Interview Survey is being prepared for a future update of the database. The combination of new case studies, methodological refinement, and database expansion clearly shows that NEED is a dynamic project. It continues to evolve. The next step is maybe the most challenging one. How do we ensure broader uptake of NEED? How do we encourage more researchers, more countries, more institutions to work with the methodology and the database? It is encouraging to see that NEED is receiving increasing attention internationally. In several other countries, such as the Netherlands, the methodology is being reflected in policy documents. NEED is being presented at high-level meetings, European conferences, and within various consortia. That recognition reflects the hard work carried out by your entire team. But recognition is not enough. The real challenge lies in implementation. International partners look first to the pioneers. We therefore need to continue demonstrating that NEED is relevant and that it can have a tangible impact on policy. The further expansion of the database is key to optimize its usefulness for researchers, developers, and policymakers. This requires the integration of additional data sets and the identification of new data sources. The team also encourages researchers outside the core consortium to develop their own NEED studies. The NEED materials, published in October, provide an important lever to support this. It is now essential to actively disseminate this methodology abroad, within universities, in research centers, and in the pharmaceutical sector. We must, to speak figuratively, go out and advocate for NEED, ensuring that partners understand its value and begin using it. And we should not hesitate to be salesmen and women for this methodology, explaining its relevance and encouraging its use across sectors. Spreading the work more widely is a shared responsibility, with a clear focus on commitment and outreach. Another important point is the fact that the NEED initiative is strongly aligned with the EU's vision for innovation in public health as outlined in the EU Statement on Harnessing Innovation for Public Health in the WHO European Region 2025-2030. The EU stresses that, I quote, "the effective use of innovation is not optional but essential." It's a core principle reflected in NEED's mission to ensure that innovation efforts are guided by health needs. The strategy notes that innovation pathways remain, I quote again, reactive and supply-driven, and highlights the need for more proactive mechanisms to channel innovation towards priority areas. That is precisely the gap the NEED initiative aims to fill, by enabling structured identification and articulation of unmet health needs across Europe. Importantly, The EU defines its first strategic objective as objective identification of the highest unmet health and medical needs with health equity at the core. End of quote. This mirrors the foundational logic of NEET, which focuses on transparent, evidence-based prioritization to ensure that innovation targets the areas of greatest value for patients and society. The strategy also calls for fit-for-purpose incentives to steer implementation research and development towards these needs while ensuring affordability and sustainable and equitable access. NEET does contribute to this by helping health authorities, innovators, and payers align their incentives and planning processes from the outset. Finally, the EU emphasizes the importance of promoting collaborative platforms to accelerate innovation, foster open dialogue, and mutual learning. Again, a quote. NEET directly contributes to this by creating a multi-stakeholder ecosystem that brings together patients, clinicians, researchers, industry, and public authorities. Ladies and gentlemen, recent years' progress demonstrates that NEET is a necessary evolution in how we identify and assess health needs. It's a methodology that is alive and supported by researchers, by patients, and policymakers. The coming months and years will be decisive. Now we must deepen, strengthen, and scale up this work. The tools are available, the expertise exists, and the need is considerable. It is essential that this approach is applied not only where it is easiest, but also where the challenges are greatest. Together, we can shape a health system that is no longer driven by legacy structures or coincidence, but by real societal value. That is our ambition and our responsibility. NEET is here to stay. I therefore would like to sincerely thank everyone who writes, thinks, and works on this project. Together, we ensure that health systems in Belgium and in Europe are better aligned with what truly matters, the needs of patients and of our society. Thank you very much.
So, with this, the Minister has clearly set the scene for today's program, given you already some highlights of what we want to talk about and where we want to go. So with all this, I want to give the floor to the first speaker, Irina Cleemput, who is a senior researcher at KCE, and she will be starting off the program. Irina.
Thank you very much, Anne. Okay. The title of my talk is Why is it important to assess unmet health-related needs? As explained already by the Minister, this study, this project and initiative is the result of a collaboration between KCE and Cienzano and is supported by the Superior Health Council, the Belgian Medicines Agency and the National Institute for Health and Disability Insurance, and financially supported by the BELSPO. So first of all, a disclaimer, the presentation I will give today is mainly based, for the largest part, on a presentation I gave at the high-level conference of the Belgian presidency of the Council of the European Union in 2024, which was focusing on a needs-driven approach for innovation and healthcare policy to better address unmet needs. So it was a topic high on the agenda of the Belgian presidency, as explained already by our minister. This was a meeting that was on invitation only, so I suppose that for many people this will still be quite new, and actually the context I will sketch today is not new, so it's not changed in any way since then, so it's still relevant. Why is it important to assess unmet health-related needs? And it's a kind of obvious question, isn't it? Isn't healthcare about addressing unmet patient and societal needs? And yet, we see that knowledge on unmet health-related needs is still lacking very often. Despite the fact that in our democratic society we have a shared objective when it comes to healthcare, we want to provide healthcare for all in an equitable access and high quality of healthcare, leaving no one behind. And all of this within a context of limited public resources for healthcare. However, despite major advances and innovations in healthcare, major unmet needs remain. For some diseases, there is no effective treatment yet, or services are inadequate. There are still many neglected diseases on which little research is being done. And moreover, our society is changing, and innovations, and this leads to new challenges and needs. For instance, antimicrobial resistance, increasing mental health problems, emerging very expensive treatments, environmental pollution, and last but not least, the huge pressure on healthcare budgets. And these are, of course, all important challenges, and yet we see that the current market mechanisms are not providing a solution. When we look at the pipeline of pharmaceutical trials, for instance, we observe a disbalance between healthcare domains. There's a huge investment in cancer-related treatments, but much less on mental health care, surgery, or liver diseases, for instance. So this leads to the exclusion of many patient populations from innovation. Another observation is that there is limited commercial interest beyond drug discovery. And also, we very often see now in our current context that products and services are on the market or are new on the market with a marginal benefit if they are already demonstrated. So we also observe this disbalance when we asked patients and providers in Belgium to inform us about about diseases with potential high unmet needs. We also see that in this slide, for instance, that these are just a few examples of diseases that are still underserved in Belgium, apparently, and for which pharmaceuticals might not necessarily be the solution or the best solution. So actually, why is there such a selective interest in some domains on health and on pharmaceutical product development? And why are there still major unmet needs in some domains? The current pharmaceutical development framework, for instance, is heavily supply-driven, and the minister has alluded to that as well. The innovative pharma industry is, by definition, a for-profit industry, so companies are accountable to their shareholders. So they have to identify and invest in those innovations that are potentially generating in the future a high return on investment. What happens, so once these innovations with a potential high return on investment are identified, they are submitted to the European Medicines Agency. I'm losing my slides here. Sorry for that. And the medicines agencies have to make a decision on it. So it's supply-driven, confrontation with a new product, and a decision has to be made. It was assumed that the existing for-profit pharmaceutical development approach would actually lead to a win-win situation, that the economic benefits and serving people's needs would actually go hand in hand. But we see increasingly now innovations with marginal added benefits to large patient populations, investments with very or relatively low financial risks, or investments targeted to areas where there is a demand or a demand can be created, but demand is not necessarily equal to priority need. We don't really know what the unmet needs are, so authorities have to rely on what developers say that the unmet needs are, to which their innovation offers a solution. And this is, of course, a step where it increasingly goes wrong. Yes. In this study, for instance, which was performed in Germany and investigated 216 drugs that were submitted for marketing authorization on the German market between 2011 and 2017, it found that 58% of these drugs that provided no proof of added benefit over standard of care in terms of patient-related outcomes. So this is not the same as saying that these drugs did not have an added benefit, but they did not provide a proof of added benefit. And yet they received marketing authorization because they were considered to do no more harm than good, and several EU member states subsequently are paying for them, even though the evidence is quite limited. There is a trend towards accelerated marketing approval based on lower levels of evidence and no requirements with respect to proof of added therapeutic value compared to the standard of care in terms of patient-relevant outcomes. These fast approvals, based on single-arm trials or non-randomized trials, surrogate endpoints, not only lead to uncertainty regarding the clinical value, but also to potential harm to patients and society. The market-driven approach and focus on pharmaceutical solutions ignores the potential of other solutions to unmet needs. Although the signals from patient and patient associations are often clear and not pointing towards the need of a pharmaceutical solution, there is still a high emphasis on these types of solutions. So to illustrate the importance of looking broader, I'll show you one example of a randomized controlled trial. It's a pragmatic trial funded by the KCE Trials program that investigated 2 management strategies for IBS, irritable bowel syndrome. So it compared actually the classical therapy, which was a pharmaceutical therapy, and the new approach, which was a diet application. So already 4 weeks after randomization, so 459 patients were randomized in this trial, already after 4 weeks, a significantly higher response rate was observed in the group using the diet application. And this persisted during the follow-up. Response was associated with significant improvements in quality of life, anxiety, depression, and somatization compared to the baseline. So therefore, the app and the FODMAP lowering diet could be considered as the first line of treatment for IBS in primary care. And besides this example, there are many more examples to demonstrate that other solutions and pharmaceutical interventions should not be ignored, for instance, preventive interventions, etc. But also for these types of interventions, it's important, of course, to know what the unmet needs are and the highest priorities for patients and society. But this is actually what is not happening now. So what we aim at with our initiative is to support the development of a system where unmet patient and societal needs are identified upfront and can inform researchers and developers on where to invest their own scarce resources for development. The aim is not to impose priorities in a top-down technocratic way. In fact, identifying unmet needs requires a bottom-up process involving patients, healthcare providers, and citizens, as will be explained later today. Moreover, the solutions to the unmet needs and societal needs should not be predetermined. So as I explained before, we should not focus only on pharmaceutical product or medical devices. It could be a drug, a medical device, but it could also another type of intervention. And as soon as the therapy or the new intervention has proven to be safe and effective, adding value to society and be cost-effective, it can be introduced in the healthcare system and pricing and reimbursements decisions can be taken. So the first step, the identification of unmet health-related needs, is a scientific approach, and this is what we aim to support with our current need initiative, and you see it's only one part of the entire product life cycle. But why are we not there yet? Why don't we have this kind of needs-driven system yet? First, there is currently no common definition of unmet health-related needs, as unmet needs are not identified, priorities are not set based on these identified unmet needs, and the current market-driven system that prevails in some healthcare sectors, combined with the fact that public authorities are not very successful in defining their willingness to pay for specific health improvements, creates a misalignment of innovations with public health needs and inconsistent decisions across decision makers. For the scientific identification of unmet health-related needs, we launched the NEED initiative, which has 4 major objectives. First, to develop a framework with explicit criteria and indicators for identifying patient and societal unmet needs. Secondly, develop standardized methodology and tools to identify unmet health-related needs in a scientifically valid manner. Make all of this publicly available so that everyone can use it. So researchers, but also companies and innovators can use our tools, can use our protocols to demonstrate the value of their products or services they are developing. And then finally, we want to bring all this together in an evidence database on patient and societal unmet needs. So the ultimate aim is to inform and support evidence-based, needs-driven healthcare policy and innovation. With that, I would like to pass the word to my colleagues. 3 of my colleagues will now come up the stage. Charline Maertens, who is PI of the NEED project. She is expert health services research at KCE and PhD in public health. Then Claudia Schoenborn is medical expert at KCE and also PhD public health. And finally, Caroline, economist, expert at KCE as well. They will now present you more details on the NEED project. Thank you.
Can you hear me? Yes, super. So good morning, everyone, and thank you very much for being here today. So we are truly delighted that you could join us. And the 3 of us are very, very excited to present some of the key methodological aspects of our NEED initiative. So first of all, what is NEED? As Irina explained, NEED aims to evaluate the unmet health-related need of patient and society. And to achieve this, the project has developed several components that constitute its key fundamental elements. So these components will be presented to you during this symposium. First, NEED is built on several methodological pillars. A selection process to identify priority conditions for the NEED research program, a framework containing criteria and indicators to evaluate unmet needs, and a protocol and toolbox that provides standardized methods and procedure for conducting a NEED study. These different aspects will be presented both in this session and in the next presentation on the pediatric component that Julie will present you. We then apply these methods and collect real-world unmet needs through case studies. And Zil Claessens from KU Leuven will present an example of a case study on psychotic disorders. Then the results obtained from the case study are integrated. Sorry, I have an issue with the pause, but it's fine. Then the results obtained from the case studies are integrated into the NEED database. And Rani Klarman and Robbie DePaul from Sciensano will provide insight into the NEED database. Finally, a very important component on the NEED initiative is networking and advocacy. To strengthen this dimension, we engage with different stakeholders to challenge and refine our methods. Later today, Valérie Paris from OECD will give a presentation on the importance on unmet need in pharmaceutical R&D funding. And this presentation will be followed by a panel discussion with Moredrek Chibi from WHO, Claudia Luati from the European Patient Forum, and Marcus Guardian from the Horizon Scanning Initiative, and Jorge Gonzalez from TIC Biomeds. The evaluation of the unmet needs is based on a 4 steps implementation approach. First, we identify the health condition that may present significant unmet needs. Indeed, given the large number of health conditions, it's not feasible to conduct an in-depth unmet need analysis for every disease. Therefore, we must select and prioritize the health condition to be included into the need research program. The timeline for each need research program has not yet been determined, as it will depend on the future on the human and financial resources available. In the third step, we collect detailed assessment of unmet need for the selected condition, and this assessment is guided by the need assessment framework, which includes a set of criteria and indicators. Finally, the last step of the implementation approach, we disseminate the results through various channels, for instance, publication, the need database, and of course, oral presentation as today. So, for the first step, on the implementation approach that aims to identify health conditions with potentially high unmet needs, we begin by establishing a broad overview of the health conditions that impact deeply the patient and the society. To do so, we rely on two main resources of information. First, we are using existing databases, such as the Belgian Burden of Disease, as previously presented by the ministers. And second, we complement this database with a call for proposal approach to patient, healthcare providers, and the general public, in which we ask them to suggest health conditions that they believe are associated with high unmet needs. This figure summarized the process used to identify health conditions with potentially high unmet needs. The process was carried out last week. So we first matched 21 conditions from the Belgian Burden of Study, so resulting in 90 unique conditions, with 105 unique conditions collected from the 300 and more or less 50 submissions to the Belgian call for proposal. And after removing the duplicates, excluding the out-of-scope condition, and omitting long COVID because an unmet need evaluation had already been conducted for this condition, we obtain a list of 170 health conditions considered to have potentially high unmet needs. So in the second step of the implementation process, we select the previously identified health condition using a prioritization method. This method is primarily based on 5 prioritization criteria. The first is the frequency of the health condition. Second criteria is the impact on the health condition on patient quality of life, the impact on the health condition on the life expectancy of the patient, the economical impact of the health condition on patient and society, and finally, the impact on the health condition on the vulnerable population. After applying these different criteria, we had a list or a short list of both more common disease, because we did the exercises separately for rare and non-rare condition. So for common disease, the health condition with potentially high unmet need were alcohol use disorders, COPD, drug use disorders, epilepsy, inflammatory polyarthritis, schizophrenia, lung cancers, depression. And for a rare condition, we had ALS, brain cancer, cystic fibrosis, myopathies, and sickle cell disease. And for the 2025-2026 need research program, we decided to select one condition for a more common condition, which was schizophrenia, and sickle cell disease, which is a rare condition. And this decision was based on the fact that there were fewer initiatives in Belgium for this health condition, and also the feasibility of the case study. In the third step of the implementation approach, we collect evidence on unmet needs for a selected health condition, and we use common a common framework with clear criteria and indicators that Claudia will present to you just after my presentation. And this is supported by a set of tools to guide the work. So this approach helps to ensure that the evidence is collected in a structured, transparent, and consistent way. So now I will give the floor to Claudia, who will give you more insight about the need framework. Thank you.
Thank you, Charline. All right, so I'll continue from here. I'm going to take you through some of the details of the framework to give you a more concrete idea of what it really contains. The starting point is always a specific health condition for which we assess the health-related unmet needs from two perspectives, that of patients and that of society. So how do we define unmet needs? They represent the gap which there is between what we consider to constitute patient or societal needs and the reality of the current situation. Of course, defining the needs could really spark long debates, and in fact, it has been the subject of much research and many discussions. Within both the patient and societal levels, we have defined three types of needs: the health needs, healthcare needs, and social needs. Most of what we measure in the framework actually concerns the current needs, with information that generally relates to the present or span up to a maximum of around 2 years back. In addition, we have a dimension that estimates predictions of these needs in the future. I will now show you what our full adult framework looks like today. You see that it is organized, again, by patient and by societal dimensions, and at the bottom we also have a future dimension. The framework is further structured by health, healthcare, and social needs. And here you can now see all the 26 criteria which make up the framework today. In a moment, I'll walk you through 3 of these criteria as an example to show you how they can be measured in practice. So just before going into that, I wanted to tell you about these 2 documents. So last month, we published 2 key documents, which are the need protocol and an associated toolbox. The reason this is very important is that besides allowing for complete transparency, it also provides all the detailed methodological guidance and data collection tools for other teams to carry out need research, and for their results to be incorporated into the need database. So you might have understood it by now, but the NEED project really relies on collaborative efforts to complete the database with data on as many high-burden diseases as possible. So what's included in these reports? The NEED protocol outlines the methodological process for conducting a NEED research project, including how to adapt the generic tools we provide to the specific disease that is being studied. It defines each criterion and indicator in detail. It provides guidance on specific aspects, such as cost standardization, reporting methods for results, and submission of data for the database. It also addresses frequently asked questions and provides key contacts. The toolbox provides all the associated data collection and data analysis tools. So you might also wonder where the data actually comes from. So the data we collect comes both from secondary sources, as in existing sources of data, as well as primary data. So new data we collect ourselves specifically for this purpose. The secondary data concerns the scientific literature and existing databases, for which we have useful tools, which are standardized search strategy for the literature, and also a checklist for some of the economic indicators. Concerning the primary data collection, one of the very central sources of data is a survey directed at patients or at their proxies. And for this, we have developed a generic patient questionnaire, and we also have an R script, which allows standardized analysis of the survey responses. As a complementary source of data, we've also developed interview guides for qualitative interviews with patients or their proxies. And last but not least, for some indicators, we collect input from clinical experts through a survey, and all these tools are available online. Now let me say a few words about the patient questionnaire. It is a tool central to our methodology. It's designed to ask patients, so the people most directly concerned by this, about their unmet needs. Developing this tool required extensive efforts, multiple revisions, and input from patients, patient representatives, and clinicians. It is addressed at adult patients and can also be used in certain cases when patients, for example, are unable to respond by a proxy respondent. We have a precise definition of who a proxy is, but in short, it is a person with a close relationship with the patient and who knows their experience and preferences well. A version of the questionnaire for children is also being developed, and Julie will tell you more about this. The questionnaire includes 55 items and covers 7 themes, namely demographic and socioeconomic background of patients, the impact of the disease on patients' health, their experience with healthcare services, and the impact of the disease on patients' social lives. Then we also ask participants to rate the importance of their unmet needs, and in case where caregivers respond to the questionnaire, we have additional questions for them, asking them about the impact of the disease on their well-being. The questionnaire is generic. This means that it was designed for use in a wide variety of diseases. A few items simply have to be adapted to the specific context, but one of its main strengths is the fact that it allows for cross-disease comparability. The survey is available at the moment in French, Dutch, English, and soon in German, and we created an online version so that it's ready for use. Another tool that I briefly wanted to tell you about is the clinical expert questionnaire. This is addressed at selected experts in the disease, which usually means clinicians with an academic experience. It is used to provide estimates for 5 framework indicators. These are the implementation of effective primary prevention strategies, the appropriateness of the diagnostic timing, the availability of treatment, treatment effectiveness, and research gaps. This survey is provided in English in an online format and has to be only very minimally adapted for each disease. So as I mentioned when I showed you the full framework, I'm now going to take you through examples of how we assess 3 different criteria. Within the patient perspective, we have a criterion which is the impact on patients' general health-related quality of life. And this is measured through 2 indicators, the years lived with disability and the EQ5D score. For each of these, we have defined measurement methods. For the YLD, for example, there is a formula, which I'll spare you the details of today, and the data collection method for this indicator is database analysis, because the data comes from the Belgian burden of disease. The second indicator is the EQ5D score, which can be measured in 3 ways. For example, one approach is to calculate the average difference between the score that patients report for their current quality of life and the score they record from before the first symptoms began. These measurements are collected through the patient survey, which I told you about earlier. Moving on to the second example, we're still within the patient perspective, and one of the criteria to assess healthcare needs is treatment effectiveness. This is measured using a categorical variable where the overall treatment for the disease is rated as being either not effective, somewhat effective, moderately effective, etc. This indicator is assessed through the expert questionnaire, which I mentioned earlier. In addition, a literature review is also usually useful to complement the information. Now we're moving on to the societal dimension. A health needs criterion is the burden of the disease on informal caregivers' health. To measure this, we calculate the percentage of caregivers who consider that their health was moderately, a lot, or extremely affected by their role as a caregiver. The main data collection is done through the patient questionnaire when it is filled out by an informal caregiver. And then, as a nice-to-have addition, we can also collect data on this aspect through qualitative interviews with proxy caregivers. Thank you very much. I'll pass the floor to Caroline.
Good morning, everybody. So Claudia gave some examples of indicators on health and healthcare-oriented needs. Now, it's important to know that unmet needs may also manifest as economic needs. And we recently worked on specifying and operationalizing these economic indicators in the framework to include them as well in the protocol. So we would like to take the opportunity today to share some more details about these economic indicators with you in this session. On this slide, you can see again all of the criteria of the framework, and we highlighted the economic criteria in blue. As you can see, the economic criteria are spread across the patient, societal, and future dimensions. So I'm just trying to use my mouse here, which does not seem to work. I'm sorry for this. Okay, I'll just go ahead with my backup. And so at the patient level, there is the impact on work, as well as the broader financial consequences of living with a disease. At the societal level, there are productivity losses, and these are intertwined with the impact on work at patient level while extending to the wider economy and society. And next to that, there is the societal concern whether and to what extent the current care represents efficient use of public resources. And finally, at the future level, we look at forecasted healthcare costs and forecasted productivity losses. Now, let's have a closer look at how we operationalized the indicators on productivity losses. Productivity losses may lead to public expenditures, such as sickness and disability allowances, and they also affect the economy as a whole. They lower overall economic output, GDP. They lead to higher costs for employers for hiring temporary staff. They lead to reduced tax revenues, etc. And productivity losses have several subcomponents, in fact. They can take the form of absenteeism, when patients are absent from work. They can take the form of presenteeism, when patients are at work but less productive due to their disease. Furthermore, patients can reduce working time or stop working completely. And finally, disease can cause productivity losses not only for the patient, but also for the informal caregivers. And for each of these subcomponents, we have an indicator in the need framework. Absenteeism of patients is measured in different ways. In the context of the need database, we collect data on both the average duration of absence per patient as well as on the number of persons absent due to the disease to get an idea of the severity as well as the magnitude of the concerned population. Data on these could primarily be obtained from national databases, and for Belgium, this means we're looking to collect data from the Knowledge Center for Work Incapacity from RESIF INAMI. These data are currently not yet in the database, but we're working on that. And in parallel, data on absence duration can be collected through the NEED patient survey. For presenteeism, data is also collected through the NEED patient survey, where patients are asked to indicate on a scale from 0 to 10 whether and to what extent the disease had an impact on their productivity at work. And for work reduction or early labor force exits, data is also collected through a dedicated question in the NEED patient survey, where patients are asked whether they have reduced their work hours or stopped working because of the disease. And the major advantage of posing this question directly to patients in the survey is that it allows us to capture causality. There may notably be various reasons why people reduce their work hours or stop working, but our interest lies only in cases where the disease was the actual cause. And this causality is something that is difficult to capture in administrative databases. Concerning productivity losses of informal caregivers, data is also collected through the NEED proxy survey, where proxies are asked how many hours they spent on informal caregiving. Let's explore the economic needs or challenges that arise when having a disease at patient level now. First of all, patients face out-of-pocket payments for healthcare services. For this, we have a first indicator. On top of that, they may be confronted with costs outside the healthcare sector, but still caused by the disease. For this, we have the second indicator. And then finally, we have an indicator measuring the perceived financial difficulties by the patients themselves. Out-of-pocket payments include co-payments, supplements, and payments for non-reimbursed healthcare goods or services. The included components may vary depending on the disease under investigation and the country where the research is done. These payments are measured per year and per patient for the database. Why per year? Well, because it's easier to deduct annual costs from administrative databases. If we would want to add up all out-of-pocket payments over a lifetime for the patient, we would need to make many assumptions on the duration of the disease, the evolution of the disease, the evolution of the treatment and associated payments, etc. And it would be less feasible to do this in a consistent way for a large set of diseases. And I'm heading to my backup again. Thank you for your patience. Now, so we were talking about presenting annual out-of-pocket payments, and this choice for presenting annual out-of-pocket payments in the database has some implications, however, especially when comparing acute with chronic diseases, as annual costs will be less pronounced in chronic diseases, while they may nevertheless lead to significant economic burden in the longer run, as costs build up over time in chronic diseases. So this point has to be borne in mind when comparing diseases for this indicator. And the idea for this indicator is also to have it filled for many diseases based on, at once, based on cost of illness data from Cienzano for Belgium. And the inclusion of these data in the database is work in progress also. And the data from databases will not be sufficient though, as they generally do not comprise data on non-reimbursed healthcare, so they will need to be complemented with information from literature and or patient interviews. So besides the out-of-pocket payments for healthcare services, the patient may face other costs outside the healthcare domain, but still caused by the disease. We operationalized this indicator on non-healthcare costs, not in a quantitative way, but in a qualitative way. Notably, we created a checklist for it. The checklist comprises a comprehensive list of cost groups, which may be applicable to health conditions. This list was developed by the NEED team and subsequently reviewed by representatives of two patient umbrella organizations. The idea of the list was to be exhaustive. Nevertheless, just to make sure no costs are overlooked, we also provide an option at the end to mention any other costs. So what cost categories are in the list? The costs can range from transportation or accommodation, adaptations to the home or workplace, to additional insurance costs, or many else. For each of these cost groups, it has to be filled in the database, whether they are applicable or not, either to most or a minority of patients, and if so, whether it concerns one-off costs or recurring costs in the short or long run. Then we're moving to the indicator on perceived financial difficulties. And for this indicator, also a question is posed in the patient survey, which allows us again to capture some causality. The interesting thing about this indicator is also that a link, a cross-check, can be made with the preceding indicators, as financial difficulties can be caused by one or a combination of those. Financial difficulties can be caused by out-of-pocket payments for healthcare, by payments outside healthcare, as well as by work reduction or work stop. And then we're moving to the next economic indicator, representing notably the concern or the need to have a balance or a proportionality between costs of care and its effectiveness. As a society and as a public healthcare payer, there is a need for having effective treatments at a proportionate cost. So for this indicator, we put the total healthcare costs on one side and balance it with the effectiveness of the treatment on the other side. For healthcare costs, we take the perspective of the healthcare payer, so included are the payments by the public payer as well as by the patient. And the idea is also here to collect data from the cost of illness data analysis from Cienzano, which are based on Belgian administrative databases. And for the effectiveness of treatment, we refer to other indicators already elsewhere in the framework, notably on the effectiveness of current treatment, the years of life lived with disability per case, and the years of life lost per case and per death. So here are some data from the cost of illness study from Cienzano. These data are based on data from the Intermutualistic Agency, and they show costs and prevalence for a list of conditions for which patients could be identified on the basis of their use of pharmaceuticals. The y-axis shows the cost per case per year, and the x-axis shows the prevalence. The size of the circles represents the product of both, so the total healthcare costs for Belgium in a year. These data are also not yet in the database, but we are working on it to incorporate them. And in the afternoon, Rani will also tell you some more on how we aim to speed up the process of filling the database. We look forward to sharing more insights on this once this work has progressed.
Thank you very much, Caroline. And so, if you remember correctly, we are now at the last step of the dissemination approach. So the dissemination. To do so, we share the findings through various channels. So first, we, as previously said, we integrated the results into the need database. We also communicate them through publication, presentation, and other dissemination tools to ensure broad accessibility and visibility of our results. We also have the NIB website, and on the NIB website we regularly publish updates and progress on the work, and users can also subscribe to our newsletters to stay informed. So to close this session, some take-home messages. So as I said previously, there are a lot of health conditions with potential high unmet needs. However, prioritization should be done for the annual research program. The assessment of unmet health-related need is supported by robust methodological resources, including the need framework, the protocol, and the toolbox. The tools are standardized to allow comparison between different diseases. The tools and methods are not set in stone and will need to evolve in response to the societal changes, for instance, the AI, and of course, including the emergence of new potential needs. And finally, all material are open access, enabling external teams to independently conduct their own needs research. Thank you very much.
Thank you very much to the team. We now have some time for questions after this overview of everything that was produced and is available on the website. I'm sure some of you will have some questions. Also, people who are following online, you are happy to post questions and we will keep an eye on them as they come in. There is a microphone available for people who have a question for us. Who wants to kick off? And if you could kindly say your name and maybe, yeah.
Hello, my name is Lies Schoenborn. I'm from Higgs, from a healthcare consultancy company. I was wondering, many diseases are chronic diseases and are also progressing, or patients are deteriorating over time. There are different disease stages. How do you take that into consideration if you look at that? Because depending on the time point, you can have different outcomes.
I'm going to immediately pass on the microphone to the people who have the inside knowledge.
I'll take the question. Thank you very much. It's definitely a super relevant question and something we have thought about a lot. I think the indicators, some of the indicators really take into account the time dimension as well. So while we say that we assess the unmet needs today, there are indicators like life expectancy, which clearly take into account diseases which are highly fatal or progressive and lead to death earlier than expected. But also in terms of the actual quality of life, because we capture a sample which is representative of the patient population, we have the different, or hopefully we have, and that's what we try to do, to get people in different stages of disease. And then we can stratify the analyses by disease stage. Thank you.
I can't see another question. The lights are slightly blurring my vision. Yes, there is one here in the middle of the room.
Yes, hello. I'm Catherine Dru from Recife Inami. So my question is about the patients. So how did you reach the patients and their proxies? How were they identified? And also, how many interviews did you conduct per disease, more or less? And how do you then, how sure are you that you identified really a representative group of patients and proxies? Thank you.
Okay, I will take this one. I think you will have some answer to your question in the afternoon, because Zilk will present a case study on psychotic disorders. It's a very important question, of course. It's very difficult. We cannot show that the sample is representative of the patient population, of course. It's a bias of our studies. It's a study that's it's on a voluntary basis, so it means that people can choose to participate or not. Or we reach the patient, we are using social media. We are also using some affiche, so we are putting affiche in the hospitals. We are spreading the word to patient association, to medical doctor association, so it's a bit like the different strategy we use to share our studies. But of course, we cannot show that it's a representative sample of the population. We try to balance. So, for instance, for the interview, so for each health condition, we have more or less 25 interviews for each health condition. And so, at the end of the patient survey, the patient are asked to say, okay, I would like to participate to the interviews. And so we have a panel of patients that agree to participate, and in this panel we try to make sure that the interviews are balanced depending on the age of the patient, depending on the stage of the disease, depending on the language, of course, because of course in Belgium we have both Dutch and French. So for the interviews we try to balance to be sure that it's more or less representative of the patient population. But of course, what we commonly know is that, for instance, for a survey we have more high educated patients, so it's more difficult, for instance, to touch the patient who are less educated, for instance. So this is something that we know. So we try to balance, for instance, for psychotic disorders, Zilk will explain, but we try to go in also to join the patient who are hospitalized for long term also. So it's something we try to do, but of course it's we know that there are still bias, but we try to mitigate them with different solutions. Thank you.
Thank you very much. I think there's also a question online, maybe.
Yes, so for the people online, I would like to invite you to ask your questions through the Q&A button. And there is one question online. what kind of questions were part of the survey for patients, and are these questions similar to the national health surveys?
Thank you. I'll take this one. So there were around 55 questions in the questionnaire, so we're not going to go through all of them. But there were different themes. So it started off with questions asking patients their age, where they live, as in the region, their professional status, both before the disease started and today, just to be able to capture people who fall out of professional activity, for example. And then we moved on to diagnosis, and we asked about, for example, the time that went by between them noticing the first symptoms and then making an appointment with a doctor and getting an appointment. Then we have the whole health dimension, which basically asks them about the burden that the disease has on them. And we have questions where we ask them to rate all their symptoms and to say for each symptom how burdensome the symptom was. We look into the treatment that they have and also ask about the burden of the treatment and treatment side effects. We ask about their healthcare experience. So, for example, to what extent the healthcare was well organized, or the continuity and coordination of care, to what extent they think that they were sufficiently involved in treatment decisions. Sorry. And then there is also the impact that the disease has on their social life. So we ask to what extent it disrupted family relations, usual activities. We have the EQ5D tool, of course, which I presented earlier. And we also ask things, for example, impact on their sexual life, impact on their reproductive life. I think I've given... And priorities, yeah. So at the end, we've newly added this question in which we ask them to kind of rate for each unmet need to what extent they think it should be a priority in being addressed. Yes.
Yeah, good morning. Els Duisburg from INAMI, Recife. It's a little bit in line with other questions, but yeah, you use a very heavy framework, in fact, to assess and identify the needs. Now, as we know, with such a framework, by changing few things, inputs, you can have a quite big change in your outcomes. That's prone to all models. Now, my question is, how will you deal with this? And then just a comment more. Yeah, the call for a need-driven system is not new at all. It exists already since last century. But my worry is a little bit how to implement what you get out of it. I know you will discuss this later, but it's something that is already so often said. We need a need-driven healthcare system. Very relevant, very rational, but how to come to this?
Maybe I'll answer the first one and leave Irina to answer the second part. So indeed, you're right. It's I think it's both a strength and maybe a difficulty, the fact that we have so much information. We really wanted to be comprehensive. We wanted to touch all areas that really affect people, because there were no good arguments to say, well, why look into the symptom area but not look into treatment of side effects, for example. So I think we've included everything which we think is complementary and should be included. At the moment, it's visible in the database. We're also working on some traffic lights, kind of more visual signals, I think, to that kind of summarize in a way to say to someone who wants to use the database, look, here there's a problem. If you have a red traffic light, it means in this dimension, in this criterion for this disease, there is a problem. Because, of course, we agree you have to, depending on who uses the database, but sometimes the information may be too much, and then you need to kind of have lesser information and be able to use just a broad signal, say. Yeah.
Yeah. It's not.
You will.
Okay. Yes. Yes, and in addition to that, indeed, so we try to be quite extensive in what we include in the framework. It's a very big framework, and if you really apply it to a specific disease, and we've done a few case studies, it kind of gives you a very good idea overall of what is the burden of this disease, what is the patient and societal burden of this disease. But we do realize, of course, that for real life use and in practice for policy making, this might be very much. There's a lot of information, and it has the benefit that it is evidence-based, so you have a stronger comparability. But on the other hand, we also know that it's very difficult to take into account more than 50 indicators or 40 indicators in your mind, just to digest them and then to compare them in a real policy-making context. So we actually also published a core need framework last year that highlights which are, according to European decision makers, we surveyed HTA agencies, etc., to identify what are the core decision criteria for you and which indicators match with these decision criteria. So we identify a smaller set within the entire framework that could be used by policymakers, but that's not enough. We do realize that this is not enough. Then you still have data on, let's say, 10 or 7 indicators, and you need a more practical tool to use this in real-life decision-making. And so this is one of our next steps, is if we are still able to, after 2026, that will be, to try to develop, together with other European countries, a mechanism to really use these data, integrate these into a decision-making process. So develop additional tools, additional means to really use this in real-life decision-making. And especially from the HTA point of view, I think this is really important, because otherwise probably it's not going to implement it. And this implementation stage, we are really aware of the importance of this, and it should be practical and feasible to use. This requires additional steps. But you cannot run before you walk. So you had to develop all these basic tools and basic methods and try to develop these protocols in order to create the scientific basis, rather than trying to apply something that is not completely finished yet. So that was a little bit the idea.
I'm just looking at the guardian of time. Sabine, do we still have time? Because I think there's one additional question online, or should we wrap up this session? And
at 3 minutes, I think.
Still 3 minutes, so we could do one more online question?
The microphone.
Okay, so there's a question online. Have you considered the medicines in horizon scanning for the evaluation of potential solution in the unmet needs conditions?
The medicines included in the International Horizon Scanning Initiative, that's the I think it's, I think my microphone is not working. Maybe now it works. Yeah. Okay. So the question is, did you consider the medicines that are currently included in the International Horizon Scanning Initiative? I think I should maybe not go too far, because there is one of the panel members in the afternoon who will represent the International Horizon Scanning Initiative. We actually think that the need approach could help to assess the potential impact of medicines that are in the pipeline. So part of the International Horizon Scanning Initiative is to collect in a database what is coming, what is in the pipeline, and also to assess the potential impact by means of the high impact reports. And we have been discussing this with the IC team, and they can, of course, because everything we do is public, and they can use this information. And so that is an ongoing part of the future work that we would like to pursue in the future.
One final question? Yes, go ahead.
Thank you very much for the interesting work. I'm Charlotte from K Leuven. I was wondering, you touched upon that you you could build or develop it further with other countries. So how did other countries do it so far? Do they have similar frameworks? Did you look into it? Yeah, that was my question. Thank you.
Yeah, we've had a few discussions with other countries. We know that the Netherlands is very interested in the approach, the more needs-driven approach. We also know that Canada, Australia, they are also very much interested in the need framework, and they also already apply some kind of approach to identify unmet needs. And yeah, also in Belgium, we have had collaborations with the RISIF INAMI, with the Unmet Medical Needs Program, so that, and there specifically we use the kind of core need framework to identify the core indicators that they would need to make their list of unmet medical needs, and apply the same principles or the protocol or the methodology that we developed at KCE. So there is quite a lot of interest, but again, in the afternoon there will be a panel, an international panel that can definitely explain you more about this.
But just maybe to complement Irina, so the framework has been validated at European level, so it means that we applied a Delphi. So it was validated by different countries. So it's trying also to have the opinion of different countries and this agreement. So it was discussed at European level.
Okay, thank you very much. I think that's all we had time for this Q&A session, but there will be more Q&A sessions throughout the rest of the day, so there will be plenty of time to ask more questions. And it's time for coffee, I think, now.